The record for the Lotto jackpot continues to tumble. And on this Friday, May 8th, you can be a millionaire with a Lotto jackpot of $1,115,000. Make your dreams a reality. A new home, car, or that college education.
Lotto, you have to be in it to win it.
Next Lotto jackpot, $1,115,000.
Welcome to another edition of Roundtable Talk. As promised, we have decided that we'd focus these discussions, these talks, on the topic of COVID-19 and all the happenings here in St. Vincent and the Grenadines. And we are indeed privileged to have on the panel this evening the two people who are tasked with leading the response here in St. Vincent and the Grenadines. And you know, they say, uneasy is the head that wears the crown. And these two really do have a task ahead of them. I speak of none other than the Chief Medical Officer, Dr. Simone KEIZER-BEACHE, and she's also the chair of the Health Subcommittee, Health Services Subcommittee at the National Emergency Management Organization, NEMO, and Medical Officer of Health, Dr. Roger Duncan. You're back with us. Third time.
Yes, third
Welcome.
time. I will go for that. I'll just say third time.
Okay,
Thank you.
Thank you for coming. First of all, give us an update, a status update on what is the current situation as of today with regards to COVID-19 in St. Vincent and the Grenadines.
Okay, good evening, Teresa. Thanks for having us. So as of today, May 6th, we still have 17 cases of COVID-19. We have 9 persons who have recovered. That leaves us with 8 active cases. We have had no deaths. We have tested 137 persons. That is the PCR test. We have currently 5 results pending, and we have 112 persons in quarantine.
And that's the status as of today?
As of today, 6 p.m.
Okay, 137 persons tested, and you're saying this is the PCR test.
Yes.
Let's talk about the tests.
Okay.
What is the difference?
So there are 2 types of tests we're currently running. The PCR test is the test where we do a swab in the nose. Mm-hmm. We're using the nose. We can also use into the mouth, the back of the mouth, and that looks for virus particles. This is the virus that causes COVID-19, so that's what we are looking for. And that swab is prepared in the lab here at the Milton Cage Memorial Hospital, and then it's sent off to CARFA, the public health lab at CARFA in Trinidad, and that's the test that we use to make a definitive diagnosis about whether or not you have COVID-19 or whether you have recovered from COVID-19. We are also doing some rapid tests, and the rapid tests look at antibodies. So you know when you have an infection, the body responds by trying to fight it off, by producing antibodies. And so the rapid test that we're using is looking for those antibodies. And so we are using those tests just to do a sort of screening. We're using them when we are doing our contact tracing, which we could talk about later. But once those tests come back, if it's positive, we would then go to the PCR, because we're not going to make a diagnosis about COVID-19 on a rapid test. We make a diagnosis only on the PCR. So that's how we are using. Those are the type of tests we're using right now.
That's a very important point, because I know that there's been a lot of concern about the testing. How do you respond to the criticism that we are not doing enough testing in the country? I don't know if Roger would like to take this one.
Well, I don't know. How much is enough testing, you know? I mean, we could stop everybody from moving today. What time it is? My watch says 6:13. Stop you from moving today at this point, and we test all 110,000 of us. We get results, but what does that mean?
But is that possible anyway?
It's not, apart from not being possible, practical, but what does it mean? Does it mean that 20 people of the 120,000 are positive and that's it, we fine, let's move on? It doesn't. It doesn't give you that sort of security people are looking for. So then these same 100 people, you know, who are negative, you're going to have to stop and test them. I don't know if it's the next day or the next week or the next month. So it goes on and on and on. In the context of scarce and limited resources for PCR testing, and Simone has indicated that PCR is what we use for diagnosis, we have to have some sort of strategy for testing. And, you know, we have to be rational in terms of how we test people and when we test people and why we test them. The rapid test, as Simone has indicated, is an excellent tool for us, especially in contact tracing. And I mean, it's amazing how well it works when we're looking back to see, you know, what has happened, what hasn't happened. And we know this conversation about what is local spread, what is community spread, and what isn't. The rapid test has been a great tool employed by us in doing contact tracing and determining what is the level of COVID activity in the community. And when I say the community, I mean the community of St. Vincent and the Grenadines. So we've been able to do that. So although you might see what you think is a small number of PCR testing, I think the rapid testing, Simone, I think has gone beyond the number we have done already in terms of PCR. So one complements the other, and it depends on what the specific situation is, you decide which to employ.
Okay, and how do you decide which one to employ, or do you employ both?
Okay, so if we have, for instance, somebody who we think is a suspect case, and there's a special case definition for that, then we'll immediately employ a PCR. Yeah, we do a PCR. This person turns out to be positive, and then we're going to do their contacts. What do we do? Depending on the period since the last contact. If that period, we estimate it takes between 5-7 days, for antibodies to be formed. We're a little cautious, so we extend 10-12 days, just to make sure that when we test you with a rapid test, that if we're looking for antibodies, and if they're there, we more than likely would pick up these antibodies. If these antibodies are positive, which means that you have been exposed to COVID-19 virus at some point, we would then do a PCR on you. And if that PCR is negative, then we would say that, okay, fine, you might have been exposed to COVID-19 virus, you're not shedding virus anymore, and you have recovered. So we're using them in tandem to try to make sure that we have a good understanding of what the level of activity is in the population.
How long does it take before someone is exposed to the virus for it to be detectable?
Okay, so it depends on, as Roger was saying, depending on what you're looking for. So if you're using the PCR, by about 3 to 5 days, you should be able to pick up the virus on the PCR. If we're looking for antibodies, as Doctor said, we're looking at around 7 to 12 days. So it depends on which test you're using. Though we know that some persons might respond a little earlier in terms of the antibodies, a little later. But generally, we prefer for you to be having either symptoms, or if we think there has been an exposure, that we look for about at least 5 days before we do the PCR. And if we are thinking about antibodies, we'll go about 7.
Let's talk about the general strategy for managing and containing COVID-19 in St. Vincent and the Grenadines. What is it at the moment?
Okay, so the strategy is this. Initially, we wanted to prevent importation, and we continue we don't want to import new cases of COVID. Initially, it was to prevent any cases coming in. We have cases now, but we also want to prevent any new cases, or to reduce, let me say it that way instead of reduce the number of new cases we have coming in. Then you want to do early detection, really quick and early detection, testing to confirm, and even as you're waiting on the test results, you do containment. So that would be isolation if we're dealing with a suspect or a positive case, PCR, and it would be quarantine if we're looking at contacts. And when we say contacts, we normally mean somebody who has been in the company of someone who is suspected to be COVID positive or who is COVID positive for more than 15 minutes and within 3 feet. 3 feet for. So 15 minutes, 10 to 15 minutes, 3 feet, and that would give you a close contact. So it's not just me passing you in the street. That wouldn't qualify.
What about riding in a van?
Riding in a van, it depends on how close you are to the person. Again, so we're looking at extended. So if we do ride in a van, if I ride in a van from here to, say, Argyle, Roger would be a close contact of me because I have been there for more than 15 minutes. So that would be a close contact. So that's what we're really doing. In terms of containment, PAHO, WHO, CAFA, they have recommended that you have you attain containment when you determine that you're not having massive increases in numbers. And just yesterday, UWI informed the heads that basically all of the CARICOM member states have attained containment. Containment not being that you have no cases showing up, but that you have managed to flatten, slow the curve. So
you reduce that R0 that we kept talking about, the basic reproductive number, which for COVID is about 2.6, 2.6, 2.5. That means that for each person with COVID-19 disease is capable of infecting 2 or 3 persons. And once you could contain it below that, then that's considered to be containment.
Contained.
Yeah.
Okay. We have 17 cases as of today. There are 9 recoveries. Is there a breakdown in terms of gender with regard to those persons who have actually been diagnosed?
Okay, so in St. Vincent, we have, for the 17 cases, 70.6% being males and 29.4% being females. In terms of the age range, we have gone between around the early 20s to the late 60s. That's the age. Okay. So we have more males than females.
Which is consistent with the global picture.
The global picture.
Yeah.
Okay. The male-female ratio being the male
more
being
males.
being
more
It's
males.
almost, globally, it's almost like 2 to 1, I think.
Right.
Is there any explanation for why there's this gender
Well, I don't know.
imbalance?
There are some speculations in terms of health-seeking behavior. For men, probably they're less likely to pay attention to any symptoms or anything, so they're less likely to go for health care. Men, apparently, we want to think are more smokers compared to women. That's probably one. But the crux of it is we're really not sure what it is that is driving this higher prevalence among men.
Sorry for cutting, but also because we're dealing with such low figures, it's kind of difficult to actually get a true picture. And remember, a significant number of our persons came from particular cruise ships. So, and that the proportion of persons there would be more males than females. So that would sort of screw the distribution in our case, but it's still in keeping with what's seen internationally, that more men than women turn up with COVID.
And also we have had basically mild cases, so to speak, so that may also have helped in as containment aspect, would you say?
In terms of generally COVID has been found to be, as we knew from early information coming out of China, 80% mild. But now that's thought to be even higher because the number of asymptomatics and the number of mild cases is extremely high. So in terms of it being, because we don't have persons who have been very sick, being a reason for probably not having spread, probably not as much, but rather this is just the normal pattern of COVID. The majority of cases would be mild.
Okay, when we come back, we'll talk some more about the last 4 cases, and we'd also invite you to send your concerns, your queries, and the doctors would be happy to respond. Back in just a moment.
The record for the Lotto jackpot continues to tumble. And on this Friday, May 8th, you can be a millionaire with a Lotto jackpot of $1,115,000. Make your dreams a reality. A new home, car, or that college education.
Lotto, you have to be in it to win it.
Next Lotto jackpot, $1,115,000.
We can all help stop the spread of germs and prevent the spread of respiratory viruses like COVID-19 and the flu. Wash your hands for at least 20 seconds. Avoid touching your face with unwashed hands. Avoid skin-to-skin contact with other people. Stay home and away from others while you're sick. Cover your mouth and nose when coughing or sneezing. And finally, clean frequently touched objects and surfaces. For more information, visit scdhec.gov/COVID-19.
Welcome back. Just before the break, we spoke about the last 4 cases of COVID-19, which has created quite some concern in our various communities. We did say that from 13 to 17 are all related. I don't know who would take this one, but what is the relationship? And how did the first case emerge or was discovered, and what happened after that?
Well, the relationship is by contact. So all these people were in contact with each other, or some people in that group at some point in time. So I guess it was 13, I think, was first discovered. And then there was some difficulties in establishing, the source of this infection, because this is somebody who had no travel history, who had not been anywhere, who had not been involved in anything that we thought would have been high risk for exposure. And, that's where it became a little challenging for us, because we now had to go back to look backwards, and you had to look as far back as you could go. You calculate dates. If you know what incubation period is, you could begin to determine possible points of type of exposure, and we go back. And when we went back, we were able to trace that person to somebody who had come into the country, who we have now determined was COVID positive at some point because they had antibodies. And from there, then we went along the contact tracing route, looking for all these contacts and looking for what we could find. It's hard work, it's a little painstaking, and it's not something that is easy to speak about publicly, or we ought to speak about publicly, because, we spoke the last time I was here about stigma and discrimination and how that sounds, and some of the conversations I'm hearing is totally disturbing, especially from not so much the content of the conversation, but to some extent, the people who are actually having these conversations, and people who I think should know better, who probably should be a little bit more tolerant, understand, a little more empathic, it's really worrying to me that we're at that level where people lack this kind of empathy. But it was some hard work for us to do. We took our time, we did it. And everybody involved in this, from case 13 to 17, were extremely cooperative, extremely helpful. They shared with us, they explained us, they showed us. They pointed out to us, they did everything that we expected of them. So we've been able to link all these cases to one particular source. And again, this is now an asymptomatic person who was just there.
Let us talk about the asymptomatic person. Explain that to us, and how that can cause a ricochet of actions further down the road.
Okay, so but before I do that, because sorry,
there was a question. Did I lose a question? Okay, I think it had to do with someone asking what is the situation with face masks, and if we have enough to supply the entire population at no cost. Also, will you be able or permitted to accept masks from folks in the diaspora? So, 3-part question there.
We're going to take that now.
You'll take that now?
Well, I don't know, Simone could take that. I mean, we would accept masks from people in the
Yes,
diaspora.
definitely.
We do not have enough face masks to give the entire population. We're trying to ensure that we have enough in both quality and quantity for healthcare workers, because, you know, we have to always make sure that our healthcare frontline workers are protected, not just the healthcare workers, our colleagues in immigration and our police and our colleagues in police. Also, we consider them to be, you know, faithful partners in this fight against COVID-19, and they are our partners. We don't have enough to supply for everybody. So if people want to donate or to make your own face masks. I mean, people have been, there's so much entrepreneurs now, people are making face masks. I think the going price is $10. I'm not sure who set the market price for this, but I don't think anybody's going above $10 as usual. And you could add filters to it and so forth. The advice, though, is that you know, once you're out, preferably you should wear a face mask. If you're in close and confined spaces, we highly recommend that you do that. So, you know, if you catch in a van, I think you should. If you're going to be interacting with people in close spaces, 3 feet and under, you should wear a mask. But we open to donations, right, Simone?
Definitely.
Yes, just let us know what you want to donate, quantities and so on, and we'll work it through with you.
Okay, and before that break, we would come back to the whole issue of wearing of a mask later down, because I wanted to ask a question or two with regard to that. But you were talking about the person who is asymptomatic.
The asymptomatic person.
Yeah.
So I am not a big fan of that expression. And Simone smiles because she knows. I think at some point, there's some people who are pre-symptomatic, okay? So probably when you have not yet developed symptoms, could very well be. And what I've discovered in some of my contact tracing and work with people is that if you were to sit with them a little while longer, they'll remember, well, I had a slight cough, but it only lasted half a day. And I did feel chilly, you know, I thought I had a fever. Of course, there's the question of recall bias, because if you start to probe, then people would think things that they've had it. But there's you know, there's that very mild symptoms that you might ignore. There are people who are actually pre-symptomatic, so it's the point where you're not symptomatic yet. But there are indeed asymptomatic people who are shedding virus. And the critical thing here is that because they're shedding virus and have no signs and symptoms, they're not really suspect. So they could gladly go wrong and they could infect Jane, all right, and Mary and Tom, and Mary, Tom, and Jane go on to further infect 3 more people each and so forth. You see what where I'm going with this? And then if all these people remain asymptomatic, then that's really where the problem is. And that is why the message for us still remains the same. Wash your hands. Keep your hands clean. Keep your hands out of your face as much as you could. Good respiratory hygiene and good respiratory etiquette. And I'm pretty much convinced that most of our spread here, particularly with that area of local transmission we're talking about, had to do mostly with hand hygiene rather than respiratory spread, rather than respiratory droplets. The evidence is not conclusive. I'm not saying this is exactly what happened, but that's my view based on the limited information we have now.
And what mechanisms have been put in place in that particular community to combat or contain further spread of the infection?
Well, I think if you were to judge from what we've been doing thus far, we've never been bringing out any big stick and beating anybody, going a corner stay there. We've been trying our best to dialogue with people, and the dialogue has been taking place with families and groups of people. And the whole idea is, how could we look out for each other? How could one person in the home make a difference? If we say, hey, when you come home, make sure you wash your hands. If you're going out, you make sure you wash your hands. If you're ill, let us know, and so you could stay away from us. So that's been one thing on the one hand. On the other hand, we've been testing. We've been testing more. We've been looking. I don't know. We've been using rapid tests. We've been using them, and we've been looking for people. Okay, and that's on the other hand what we've been doing. Our healthcare workers they're really active, and even it doesn't matter the size of the community, the size of the healthcare staff in that community. We've moved other healthcare workers in, even if for a period of time, to add more feet on the ground, put more hands on the deck, and try and see how much more we can get done.
Have you had a situation where people have actually been volunteering themselves to be tested in this situation?
Oh yeah, endless. People are turning up and putting their hand up, I want to be tested. And we have to try and explain in some instances, but we really don't have a reason to test you. why should we test you? We've done some of that random testing. So some people turn up and we say, okay, fine, we'll just take a sample from you. And we do that testing also. But people, by and large, are not objecting to being tested. People want to be tested, and we're willing to test as long as we make sure we can do that in a sensible manner, in a manner that is sustainable. So we don't utilize our resources, and then when we really need them, they're not available.
Have we exhausted the testing mechanism in this particular area?
We have, because as Dr. was saying, we've been very aggressive. He's been very aggressive. He is a very good contact tracer, and he has followed all of the
I'm not a Mako man. I know she's implying that.
Yeah, so Dr. Duncan and his team, they've followed all of the leads, and we've gotten to the point where all of the tests have been negative. So when you get to that sort of place where you're no longer finding a trail, you're no longer getting any positive tests coming back, that's when you know you have exhausted that, and we think we have definitely tracked everybody, and we now think that is contained.
But we still alert, though. We still alert.
Yeah,
Pipelines are still open. Conversations are still being held.
Okay, what is being done to deal with the issue of stigma and also to mitigate the effects as such? That's a question coming in from Evan B.C. Roberts.
Okay, so that's a difficult one, and it's a challenge because there's a lot of fear, and persons are looking at television and they're seeing, in the US, in New York, numbers. Now they're tapering off a bit, but this morning I think they were around 71,000 deaths. And so people are afraid. They feel that if somebody gets COVID, you're going to die. Has not been our experience, but there's still that sort of significant anxiety. So that we have had instances where the majority of persons have been reasonable, but we have had situations where a workplace might decide, okay, you're from a particular area, so you better stay home, and that can be difficult. Where the majority of persons have been willing to be tested, have asked to be tested, we have had some instances where some persons have refused, and they do not want us coming in our space suits. They don't want to be associated in any way in this. So what we're trying to do is to continue the education, to reassure persons that it is better to know, and also reach out to business places, employers, that just because someone might have been in contact with your employee, that does not mean that that person is a risk to you. If necessary, we might, to reassure some persons, you might go as far as saying, okay, we can probably do a test, if you realize that there's that level of anxiety. But definitely, it's the letting persons understand what the real risk is, and that if we make persons so fearful of coming forward, that is going to bury the disease and make it even more likely to spread undetected. We want persons to come forward. We're going to try as much as possible to make the testing process as little a spectacle as possible. But it is extremely important that we don't bury the disease because of fear.
You spoke about the importance of personal hygiene. In a particular case, which we alluded to earlier on, are there any challenges, environmental challenges, that would sort of prevent people from being able to properly observe some of these practices?
Well, I think the greatest one before us is this drought. I think that's an important thing, and I think particularly of my friends in the Grenadines in particular, and how difficult it's going to be for them. And so it's challenging. So you have to actually sit and make a conscious effort to, and even when you're doing your water, know how I'm going to use my water, how much water I'm going to put up, how I'm going to use it, make sure you have enough for taking care of your hands and keeping your hands clean. And of course, there are the other options. Hand sanitizer is scarce. I think very early in the game, The people in Beckwith, where you want to know, started making their own hand sanitizers way early in the game. And, they've been very good at that. So you have that kind of innovation that is also taking place, especially among the children, and that's good. On the other hand, there are some things in terms of workplaces, social establishments, and so on. And you have a responsibility and obligation to your patients to allow them this opportunity to do hand hygiene. It's not only in their sake, it's also in your sake. Because, Simone was just talking about stigma and discrimination in the workplace and what that could mean for your business. So, we have the difficulties, but we also, need people to come on board and to help us to sort of encourage people more often to sanitize their hands, to wash your hands, to keep your hands clean.
We'll be back in just a moment.
Preventing COVID-19 in your workplace or while teleworking. There are several things you can do to protect yourself and others from COVID-19 in your workplace, whether you are at your work site or teleworking at home. Follow distancing measures issued for your location and stay informed through information from trusted sources, such as WHO and your local health authority. Stay at home and avoid direct contact with anyone if you feel unwell or even have a mild cough. This will help protect your colleagues at work and your family members at home. If you are feeling well and need to go to work, you can reduce your risk of catching the virus by avoiding crowded public transport. If possible, go by bike or walk. Otherwise, if possible, discuss with your supervisor if you can work from home. At work or at home, if you can, use the stairs instead of elevators. Avoid using your hands to touch common objects like elevator buttons, door handles, or staircase railings. If you work in an office, create distance-based meetings either through video conferencing or by maintaining at least 1 meter space between people in the same room. If you work in contact with the public, stay at least 1 meter away from others as much as you can. After commuting to and from work and throughout the day, clean your hands frequently and thoroughly. Avoid touching your eyes, mouth, and nose. Ventilate your workplace regularly, keeping the windows open if possible. Make sure tables, door handles, and other frequently touched surfaces are disinfected regularly. Avoid crowded places and unnecessary public activities. Find no-contact ways to greet your colleagues and express affection to your friends and family. While maintaining physical distance, stay social. Contact your family and colleagues regularly to check how they are coping. Remember to seek ways to stay active and positive. Stay healthy, and let's all prevent the spread of COVID-19.
Welcome back. I think we had a question before we go back into a third segment. Is the question up? That's not a question. Okay. Are you willing to share your contingency plans to deal with the influx of sailors who will be coming in soon?
Okay. So we have established protocols, and these protocols are aimed at decreasing, again, the importation and keeping all Vincentians, including the sailors, safe. So as of now, we have about 7 different cruise ships, cruise lines, they have indicated, 6 indicated that they have sailors to bring in, and we're looking at around 650, around that figure, in terms of those who have indicated persons coming in. So the aim really is to identify where those persons are coming from, and that is going to determine their risk, because we know some cruise lines, some ships had cases of COVID, some did not. And we also have to determine where those persons have been in the last few weeks, so that we can establish what their level of risk of their exposure is, definitely. So we have asked the cruise lines to provide us with that information. We have also asked them to provide us with even more specific information. Who has been exposed, who has been tested, what's their level of health, and in terms of where they will stay when they come here. 650 persons, or even if you say we have to look at somebody, quarantine a group of, say, 50 persons. If we are going to say those 50 persons are going to go home, that is going to be a significant strain on the healthcare providers in terms of monitoring those persons in quarantine. So what we propose rather is that those persons should be held in groups, but not in a barracks-like situation, but where we can ensure that they have a separate room with a separate bathroom, and we can maintain constant monitoring of them to make sure they remain healthy. So basically our plans have to do with being able to quarantine safely, monitor, and test. In terms of persons coming out of quarantine, there'll be some sort of objective testing. So whereas before we might have just done no fever, no cough, no cold, we might still look at that, but we are moving more towards a much more objective thing, some sort of testing, because of our knowledge of the presence of the pre-symptomatic or asymptomatic or very mild symptoms. So that's what we have put in place. So we would be implementing for all of our fellow Vincentians when they come home to keep them safe, keep their family safe, because you don't want somebody to come home. We let them say, we say, you're fine, you go to your family, and then we have a family that's infected, and we start this whole process of spread again. So that's what we are aiming to do.
I know a group of Vincentians came in today from the BVI. How did that go?
Went pretty well. We're happy to have them home. I mean, and they look happy to come home too. Yeah, it was a little slow because we had to do some screening, which included completing a questionnaire, temperature check, and we did some other investigations that we would probably see what the results are later on. But it went pretty well. People were very patient with us, and I mean, no one was upset that I noticed in any case. But I mean, they were a happy bunch of people who were really, really happy to come home. And we were happy to have them and to work with them. I think it's probably the first time we screened such a large, what we did before, Yeah.
Besides, when we did the persons coming out of the U.S.
Oh, right, yeah.
Flights,
when we did the flights, right. So, and this one was a little more intrusive in terms of the screening that we did. But it went pretty well, and people were, I think they were by and large happy.
So there's an designated area at the airport which facilitates...
Well, the grand thing about this airport is it's so big. So you have areas. So we were able to, in this instance, deploy a little isolation tent so we could keep people out the sun, out the elements in case it had rain. We're hoping for some rain, though. So in case it rained, then people would have been protected. But we had deployed a tent with different compartments, and people simply journeyed through one end and exited through the other end before they got to immigration.
So is everybody being quarantined at home?
Most are being quarantined at home. What we'd done, we'd spent the last 2 weeks, because this flight should have come several times before, but we've been very diligent with the work in terms of investigating each person's home condition to make sure the conditions were ideal for quarantine. Again, the level of cooperation from these people was really amazing, and there are those who chose to rent their own apartments to make sure they could social distance from their families, and those who didn't have adequate home quarantine facilities were placed in a public government facility for the 14-day quarantine.
Okay, and after 14 days, everybody would also be investigated again?
After 14 days, people will be investigating again, and then we'll make a determination.
Okay. Let's talk about physical distancing again. I know that is one of the main recommendations for preventing the spread. How has that been going here in St. Vincent and the Grenadines?
I think it's one of the main things. If you do nothing,
I've been seeing
if you distance
crowds.
yourself, right? If you distance yourself, then that is, that alone by itself could significantly
impress upon our audience the importance of doing this.
But I am not so sure. I had, and it's interesting too. I went to the supermarket the other day. And there's a paper out from the psychologist about it's not that people are impatient, it's something about planning and so forth. But I got a little impatient because I thought that I really shouldn't be standing out here for so long. And then there were people crowding on you, and people are coming closer and so forth. And then, I was complaining to somebody who was next to me, and my wife was telling me, well, social distancing is a personal responsibility. So you have to make a decision. Are you going to, stay there and be jammed upon, or are you going to jam up with people, you're going to leave? And that is the key thing. It is your responsibility as an individual to make sure you keep that physical distance between yourself and another person. And I see people, well, don't talk with a lot of boots. Oh, sorry, I'm a visit. I shouldn't be saying that. All right, I'll take that back. But people are still gathering in all sorts of places for all kinds of reasons. And it's almost as if they don't care, as if they have no clue what is going on.
The social welfare offices as well.
Yes.
The post office.
Yeah, everywhere. And we really have to think about what it is that we're doing. I know it's difficult. Some business places have reduced opening hours, so you have to try to, get your business done. But you could do that. If you keep your distance, there's a line, so you keep your distance in that line, you're going to get into the bag. You're not going to lose your space. You don't need to drum up or you don't need to run under somebody. But please, people need to distance yourself. And that, if we do nothing else, let's do this one.
Let's talk about the whole question of cluster, local spread, community spread. Can we differentiate between all of these terms? Because I noticed that they have been creating some stir, for want of a better word.
Well, quite a stir, it seems. And okay, so if we talk about local spread, we're simply saying that there's someone who has COVID-19, who came into the country with COVID-19, and then had given it to somebody in the country. So this person who has it now has not traveled anywhere, and we know for sure this is where they got it from, and that's local spread. Community spread occurs when you simply can't find the source of the infection. Somebody has it, you have no clue where it came from, okay? So those are two different things. And a cluster means that there is a group of people around this imported case who are COVID-19 positive, and that's what the cluster is. But I tell my friends, the important thing here is not to talk about local spread or community spread and if it's this or if it's that, because the advice for you, the public, remains the same. Distance yourself, wash your hands, respiratory hygiene. If you're sick, don't go to work. Call ahead before you come in. It remains the same, local or community spread. What the difference is for us, we're in public health, because the actions are going to be a little different. So community spread, we probably have one type of reaction. Local spread, we have one type of reaction to that. Community spread, then we'll probably have to employ other measures. So for you, the public, please don't let people scare you with this local and community spread. We're all going to die, we're all going to get it. It's gone, it's mashed up the place. Don't bother that. You do what you're supposed to do. Do everything we've been asking you to do before. Wash your hands, distance yourself. Good respiratory etiquette. If you're sick, stay home, do not go to work or school. If you're ill, please call your doctor before you turn up to the office or your clinic before you go. And that is the key message. So, local, community, and it's just like, I don't understand.
It's just a term. I've heard people say, local and community, same thing. Well, it's still spreading, but
it's for us in public health. It's just to establish that we could relate each case of COVID-19 to another case of a source of infection, and that's what it is important for us.
Great explanation, Doc. You continue to send people home to quarantine. How can you be certain that these people are disciplined enough to stay quarantined?
Well, what I'll ask the person who's asking a question, would they be disciplined enough to stay in quarantine? So if you think you're able to do it, then clearly somebody else could do it. Okay? But then we have other mechanisms. We have ways of following up. We could follow up physically, we follow up by phone call, we follow up to different agencies. So in every how much health centers we have? 40, 41. There's a population around that health center. We have people in that health community that would follow you. The police are great partners in this and so forth. So, I mean, we have to trust our people, on some kind of level. We don't have enough public quarantine facilities in the country to put people in, and that's reality. And it's not just in St. Vincent, it's happening all over. So we really need to try and engage people more. I mean, we've explained to people what quarantine is. I mean, today we've provided them with a checklist of what they should have when going into quarantine. That was sent to them before. We've given them cards and numbers and who to call and what to call, and we will be following them beginning this very evening.
So, and let's differentiate before we take the break between quarantining and isolation.
Well,
isolation is for a sick person. So if you become a suspect, so we think you might have a fever or you think you might be a suspect for COVID and you have to stay at home or you have to stay away from, that becomes as isolation. If you are well and you have just been, say, a contact of somebody who's known to be positive, or say the Vincentians who came in today, because they're coming from somewhere and we have a policy where wherever you're coming from right now, you are considered to have been exposed, and so you are going to be put under quarantine. So quarantine is for a well person or somebody who has just been exposed, who is presumed to be exposed rather, and isolation is somebody who is known to be COVID positive or suspected to be COVID positive.
When we come back for our fourth and final segment, we'll talk about living well with COVID-19. Back in just a moment.
There are two ways in which we can measure the extent of infection of COVID-19. The first is to find active cases. That means who is infected right now. We do this through surveillance, and we use a test called molecular testing, or PCR testing, and that finds active cases. The second way in which we can measure the extent of infection is through seroepidemiologic studies. These studies will measure the level of antibodies in a person, and antibodies develop 1 to 2 weeks after infection. And through these serologic investigations, what we can measure is the number of people who have these antibodies, and this tells us how many people had been infected with COVID-19. Some countries are considering the use of an immunity passport or certificate to indicate that someone who had been infected with COVID-19 is now immune to the virus. From what we know right now about the tests that are able to measure an antibody response in an individual who has been infected with COVID-19, we don't know if that antibody response actually means that they're immune. These studies are currently underway. We're also concerned about the use of such a certificate because it may mean that someone who has the certificate will not adhere to public health measures that they need to continue to adhere to. We expect that people who are infected with COVID-19 develop a response which will provide some level of protection. There are studies underway right now to determine how strong that protection is in terms of immunity and for how long that will last.
welcome back. Living well with COVID-19. I know that going forward, that's really the plan. How can we live well with COVID-19? Because from all appearances, it is the new reality. It's going to be with us. How do we live well with COVID-19? And what are the plans that are being considered to live well?
To live well. So the reality, as you said, it's here with us. It's estimated that it might probably be another wave in the flu season coming up to the end of the year. And so rather than us sitting and hiding away, and expecting that this thing is going to go away, we have to learn how to continue with our lives and actually probably to even improve on the way we live. So we talk about, for example, in our healthcare system, we are talking about how do we improve on the way we take care of our patients? How do we improve on, say, the way we have outpatients clinics? Do we try now, because you're going to want to maintain the social distancing and improve on the hand hygiene, how do we improve on the time, use this opportunity to spend probably more time with our patients, have fewer patients, because we have fewer persons in the waiting area, but also encourage a much more in-depth discussion when somebody comes into you as a patient, and therefore improve that rapport and that management of that diabetic or hypertensive. That could just be one way in the healthcare system in which we live better, live well with it. You can also think about our diets. Because of the problems with supply chains, we are being pushed a bit more, probably, in terms of using what we grow. So, and we have been talking about using our vegetables, our carbohydrates, our breadfruit, those sorts of things. Less processed foods, more fresh foods. How can we live better in now with COVID? And so not that we are going to isolate ourselves in terms of from each other, but how do we adjust the way we live on a day-to-day basis to ensure that we come out as a much more healthy, a much more well sort of individual.
Doc, you out in the community.
Well, in the community, and that's just practice point Simone was making about how we run our clinics and what we do there, and probably to have a more family-centered sort of approach to what we do for our patients. One of the things about healthy living, though, is that because I spoke a little earlier about empathy and so on. If this thing doesn't teach us anything at all, it should teach us to be humble and to be able to empathize with people. I mean, we sit, we watch television, we see what's happening. We saw what happened in Italy. We saw what's happening currently in the UK and the US. And we have to learn to be a little more gentle with each other, not as abrasive as we've been and always seem to be in a hurry going somewhere. We need to slow down a little bit and think a little bit more of ourselves. And if we think of ourselves, then we're also forced to think of our neighbors and our friends and how well they're doing. And I think that is in terms of the healthy living, that is going to help us a lot. Because clearly, if you could wake up every morning with that kind of attitude and that kind of spirit, I think it's going to be a good day, not just for you, but for all of us.
Okay. I noticed the UK Health Minister saying today that survival is not just going to be for the fittest anymore, but for the smartest.
Yeah.
Yeah.
And that's what it's about. How are you going to live better?
So is there a plan to help people live better as far as the Ministry of Health is concerned? A specific plan?
So we're working on our Live Well With It program, which would include, a lot of it has to do with the psychosocial support. Because what we're realizing too is the isolation, the anxiety, because persons in terms of how am I going to make a living? So we are very concerned about that. We're also concerned about our healthcare workers because this is an unknown, You expect certain things to happen in a certain way, but now we are faced with this great, what seems to be an unknown, this increased risk, this chance that somebody can present in front of you and can be the person who is going to give you COVID. So we are very aware of that psychosocial challenge. And so part of our program is going to focus on the mental health, the psychosocial balance, the living well in terms of emotional, spiritual, all of those ways. So that's one thing we're working on. And as we said, we're working on how do we improve the way in which we provide health care. We know that diabetics, hypertensive, persons with non-communicable diseases are greater risk, our elderly. How do we ensure that our elderly, they are receiving their health care? How do we protect them in their homes? How do we protect them when they come to clinic? How do we make sure our diabetics and hypertensives are well controlled? So those are the sort of things that we are focusing on. We are going to use already established programs. So for example, the project we have, the Prevention of Diabetes project from the Taiwanese. How do we better utilize that project to ensure that our diabetics and hypertensives, they're well controlled, but they are living well even in this time of COVID.
Will telemedicine be a part of this in any way?
We're looking into that. As you know, there's some challenges with that because you might have some of our older persons might not be as office-ama, but some might not be. So in some instances, we might be doing that, but you would have to have multiple ways of communicating. So we might be doing some telemedicine depending on the situation. We might be doing clinics outside, you might have to set up, we have a vehicle, our health promotion vehicle, which allows us to go to a community. We used it on May Day, and we can set up a display in a park, which would allow for fresh air, physical distancing, and we can provide the education there. So many different ways in which, we would be able to deliver on what we need to do.
Okay, as we wind down towards the end of this segment and the end of the program, what is your schedule like, say, in the next week or two? What's happening COVID-19 wise?
For COVID-19 wise, I don't have a clue. I'm at her disposal. So you have to try to fall asleep before she calls. But we still have some capacity building to do. That's going to help us to flatten the curve a little bit. And the next week, we're going to have to introduce some more technology for the work we're doing. So that's going to help us. Again, that flattens the curve in terms of the speed with which we could respond and how easy we could share information among health team and health groups. So that's going to take a big chunk of our time. And of course, the continuing surveillance, collecting samples, having them processed and having them sent off. I just want to clarify one thing a friend was asking. I think the dashboard we had yesterday said that there were results pending and it had 0. And people are like, why are you not testing? Why are you not testing? We're testing every day. We test every day. The simple matter is that we only put up tests pending when they've been on the plane and when they're in Trinidad and when it's in receipt, the laboratory, then we'll say that these tests are pending. But while we have them at our local lab where they're being processed,
and they're not en route.
Right,
once they get to their destination.
Right, exactly. Then we'll put those up. Okay.
There's the dashboard.
Yeah, that's the dashboard is up. Yeah. And see how it looks now. We have 5 pending results. So we tested the day before, we tested today 2, and we tested yesterday. And sometimes if there might be a delay in results coming out, people might think there's nothing sinister. There's nobody trying to hide anything or to do anything, as people have very well discovered. And I said this in the very first program, we cannot hide because the Caribbean Public Health Agency is obligated to publish the results. All right, but what we do with our results is that we don't like to put our results out without, first of all, informing the people we've tested.
Okay.
And if results come back at 10 o'clock in the night, I'm uncomfortable waking you up at 11 o'clock to tell you what your results are. So we say, look, let's delay this until in the morning. So when the results come back, I have to make sure that the people who took the samples know what the results are. The people from whom we took these samples know before we put it in public. Because you put it out in the public and then, you're home thinking, is it me? Is it not me? Is it who? Is it what? And there's nothing sinister, people, please. There's no big, conspiracy here. I'm not that smart to get involved with conspiracy theories. Okay, so it's just that. That's just what it is. So sometimes there is this delay, and please understand that's the reason for the delay, because we want to make sure that everybody we've tested are informed of their results before we publicly release these results.
I just want to add to that. The results, CARFA, the lab, runs the results. They send them to us. We ensure everybody is informed. And then we have to notify WHO, World Health Organization, International Health Regulations. When they have been informed, and we can inform them within 24 hours, so that gives us time to make sure the persons we have tested have been informed. Once they then publish on their website, and PAHO publishes on their website, that's only when CARFA, because even though CARFA is running the tests, they are not allowed to publish the results until WHO publishes the results, and then CARFA is allowed to put it up. So that even adds sometimes to the delay.
So that is the information flow from testing to actually releasing the results.
Yes.
Thank you, doctors, for clearing that up. I think that was very important because we hear the conspiracy theories ourselves, so it was very good of you to clarify that for us. As we go forward, what would you like our viewers to take with them?
Well, again, I've said it all evening, and I hope I don't get tired saying it. Wash your hands, please. Keep your hands clean. Keep your hands out of your face as much as you could. I know we're all beautiful people. We like to touch ourselves a little bit. But let us try not to yield to temptation for this. Okay? Respiratory etiquette. Again, if you're going to cough or sneeze, do it in a tissue, do it in your elbow, dispose of that tissue, and wash your hands. If you don't have to come to town, please don't. You know, if you don't have to leave your house, don't. You don't have to join any crowd anywhere, and if you're going to join a crowd, try and make sure that you keep that distance that you need to keep. Once we do this, I'm pretty certain we all should be pretty okay.
Yes, and just to thank the public for working with us. As we always say in the Ministry of Health, it's a shared responsibility. And if we look at the way in which our curve is going compared to the curves in other islands, I think, you know, the public, they've been doing a really good job. And so we're just going to encourage them to continue doing that, continue washing the hands, maintaining your physical distance. And if you cannot, then you wear a mask. And, you know, let's work together to keep this under control, and let's live well with it.
Thank you very much, Chief Medical Officer Dr. Simone KEIZER-BEACHE and our Medical Officer of Health, Dr. Roger Duncan. That's our program for today. Thank you for joining us, and do remember to practice proper hygiene and the correct etiquette, and we'd all be good. Your health is your wealth. Have a pleasant evening.